Okay, my name is Arash Rashidian. I'm Director of Science, Information and Dissemination in the WHO Regional Office for the Eastern Mediterranean. I have the pleasure to be with you for a very important session on questions or challenges in enhancing national institutional capacity for evidence-informed policymaking. I'm also honored to be sort of co-hosting the session, co-paneling the session with a group of esteemed researchers and policymakers that are with us in this session. I will quickly mention that we will have presenters from Sudan, from Yemen, from Iran, Lebanon, and then we also conclude by some remarks from a colleague from the WHO regional office. Before each presentation, I will provide some introduction to colleagues so that you know colleagues better before they start talking. In terms of the objectives of this session, basically what we are focusing on is the issue of institutional capacity for evidence-informed policymaking. This is an area of major interest for policymakers. However, for different reasons, because of the sort of challenges in terms of the capacity, also challenges in terms of the different understandings of the concept may not have been adopted sort of in a systematic way. In that sense, I mean, it's really important to look at it from different angles. And what we have with us, I mean, 4 countries with 4 very different experiences. I mean, in terms of situation, we have countries among us that are dealing with sort of acute conflict. So policymaking becomes really difficult. Countries are dealing with economic hardship, countries that have a sort of a history of action on these issues. So there is a variety there. So I'm sure there will be a lot of lessons to learn. I'm also encouraging you, dear participants, that please share your questions in the chat box that exists on the portal. So there is a Q&A section there, and I'm encouraging my panelists that kindly respond to questions if they wish to on the portal. Otherwise, hopefully we will have some minutes to go in the end to take some key questions. By that, I start my own presentation. So to give some background to the discussion that we are having. Every presenter would have only 10 minutes to speak, so it's a very short period of time. And so, in that sense, we sort of remain focused on the main issues of interest. Okay, so as the topic of my talk is actually the topic of the session as well. And by the way, I would like also to mention that, I mean, this session was planned and followed by an excellent colleague who is a panelist with us. Hopefully she has a technical problem to join, Dr. Hania Sajjadi. So hopefully she will be with us very soon. Okay, so when it comes to evidence-informed policymaking, what is really important is to think of what policymakers usually ask about. So policymakers' questions are, generally speaking, of 4 categories. They ask what are the main priorities, what are our main problems, issues for decision making, how sort of those, what are the things that we need to focus on? Is there solution, effective solution and safe policy options for those priorities for policy questions? Whether those policy options are cost effective and do we have enough money? Are they affordable? Enough money to do it? And whether they are feasible to do. I mean, can we really do it? I mean, does it work in our country, in the context? And if we do it, can we keep it going? Is it sustainable or not? So, I mean, those are the 4 questions that they have. For these 4 questions, they need different types of evidence to be able to answer those questions. So you can see in my presentation, there are different categories. For example, you can use surveys, household surveys, facilities. By facility, we mean, for example, a clinic, a hospital, or user surveys. I mean, patients who visit these facilities to see, I mean, sort of understand, for example, their problem, their challenges, their issues, and these issues apply to all 4 categories of the questions. There is a lot of routine information and also surveillance programs that collect data. They can help answering the first 3 questions. The body of research, interventional randomized controlled trials, cost effectiveness studies, they are mainly focused on the two middle questions, two very important questions, whether there is effect, whether the options that I think are the solutions are effective, and whether they're worth the money and efforts you are going to put into that option. And then what we call qualitative study, that means asking about perceptions, understanding, views, can help mainly the question first, the first question about the priorities and issues. And also the last question is that, so how, I mean, whether something is effective, why is it effective? Is it feasible? But is it sustainable or not? So that's the sort of evidence. But then we know globally, also specifically in our region, there are challenges in answering, and by our region, I mean sort of Eastern Mediterranean region, which is 22 countries from Pakistan to Morocco. So within this region, I mean, there are challenges in terms of availability and relevance and timeliness of those evidence that I'm talking about. So then there are also knowledge products and processes that help development of policy briefs, although they are used in different meaning for different meanings, but I mean, if you use it in the correct ways, guidelines, technology assessment reports, data fact sheets, etc. And today I'm really glad that colleagues will refer to such experiences in some countries of the region, which will be great to hear. So what are the situations? There are good examples of, for example, health technology assessment programs. We can refer to cases of, for example, in Iran and Tunisia. In terms of guideline programs, the case of experiences that happen in, say, Saudi Arabia, in Oman, other countries. In terms of policy brief development, case of Lebanon is quite predominant in terms of progress on that situation, also in terms of Iran. In terms of surveys, observatory, we can talk of the experience that Sudan has had, or the issues that the experience that we have in Pakistan. So there are few good examples for that try to generate the evidence and put it in the right situation for countries to make. But these few examples do not necessarily answer all those questions. What we see really is that even when the countries have programs, they look scattered. Different teams, parallel teams are doing different issues. While we're really looking for, when we talk of institutional capacity, an integration of those programs together, having the issues of from health technology assessment to ad hoc monitoring and evaluation and surveys, all together, that they talk to each other, they are linked to each other, and they integrate to support policymakers. Okay, so you have that background. Then what has been the sort of what WHO has done and decisions? So you see RC and WHO. RC is the regional committee, the meeting of ministers of health in Eastern Mediterranean region. WHO is the global committee of the WHO. All ministers around the world meet each other every year and make decisions. And this is the timeline of sub-decisions related to evidence-informed policymaking. What they show is that there is a strong political commitment. So ministers have again and again made commitments to the issue. But when you look at the details of those decisions, most of them, they lack advice on institutional capacity. And we were very lucky, I mean, sort of, I go to the details of that. In 2019, in the regional committee that was held in Tehran, the ministers of health of the region, they decided on a sort of a regional plan, an ambitious plan to establish those, I mean, mechanism for institutional requirements. So a framework was developed, it was approved as part of the process. The framework talks about different types of countries. It talks about the minimum institutional capacity. So the statement that is here, that is part of that framework, it looks perhaps, I mean, easy if you think of it from an academic perspective. If you look at it from a sort of policymaker perspective in a ministry with so many questions and so many areas, you will realize, I mean, doing this on a systematic basis, institutionally, is not an easy to do. So this is the minimum requirement. But then the issue is that, as I said, I mean, there are several programs that are related to each other, and all of them need to work. They need to exist, and they need to work, and then work together. So, and when we talk of integration, from country to country, it may differ. It could be about programmatic coherence, linkages. It could be about sort of being together under one umbrella as a program. So these are countries' approaches, decisions that they need to make. So this is the first thing that they need to consider. And these dimensions we have discussed in the technical paper, and I put the reference in my last slide for your reference. So about those issues. The second thing is that whether the country is going to adapt other countries' guidelines. technology assessment recommendations, or whether they want to generate new ones. What's the plan for that, and how they decide on that? What is the role of academic institutions? In our call session today, we have two colleagues from two different academic institutions. They give experiences on that. How do ministries of health partner with them? Do they collaborate? What would be the roles of them? How? What is the role of other stakeholders? And how standardized the process is? So the last question might look, sort of an already known answer. You really want it standardized, but think of it. A policymaker deals with many questions through the year. Do they need to answer all questions following a standardized approach or no? Certain questions should be prioritized for that. And that's very important. So then it's very important that when you develop such sort of processes, they have a plan to ensure these processes following the to the end, what their aim is. You bring evidence to change policymaking, to improve policymaking. By that, it doesn't mean that necessarily you change the recommendation, but you inform the recommendation. Whatever decision of the country is, I put that those options that countries may have, two conditions should always be met. There should be a clear management of conflicts of interest in the process. By that, you should ensure that people who are sitting on the decision making and are part of these committees, they are not conflicted because of financial interests, professional interests. So that's really important to correct. And the second thing is that the process should ensure that policy recommendations are considered, even if the decision or policymaker is not based on that recommendation, which is understandable. Evidence does not necessarily give everything you need as a policymaker, but they need to consider it for it. So these are the two conditions countries should make. So then obviously the countries of the region, the framework divides countries of the region into four categories. Countries with limited academic resources, because then your approach will be different. Countries in emergency, small countries with a strong academic capacity, and large countries with a strong academic capacity. So different levels of recommendations are provided within the sort of approved framework for the region. And then how WHO is going to support different categories of the countries. And this is my last slide within that, and we hear about the details of this in the last slide presentation that Dr. Khairanish will give. So is that sort of an action plan for the work of WHO with the countries, and also a network of institutions to work together. So I stop here. So my presentation. So in that sense, what I tried to do in my presentation was to give sort of a perspective of what's happening in terms of the regional programs in the long run, supported by WHO for evidence-informed policymaking. Now I have the pleasure to invite the first speaker of the panel today. So that's Dr. Abda Hakim from Sudan. She's the Director of Health Policy and Programs within Sudan Federal Ministry of Health, and well experienced in the areas of policymaking, a lot of experience that she brings forward. Dr. Abda, so I'm giving you the floor and reminding you, you have 10 minutes for your kind intervention. Please go ahead.
Okay. Thank you very much, Dr. Arash. Can you hear me?
Yes, your sound is very clear, and I think your slide is also coming up. Yes. So just make sure it is, yes, panel presentation.
Okay. So hi everyone. I am Dr. Abda Hakim. Greetings from Khartoum. I will talk briefly. I will do my best to talk within the 10 minutes about our experience in Sudan about evidence-based policy making. My presentation will contain 2 slides about background about the country, the history of evidence-based policymaking in Sudan, the types of research or surveys and evidence we generate, the usual ones, the role of evidence generation in promoting our health programs in the Federal Ministry of Health, and the institutes that do deliver such evidence, some successful stories regarding decision based on evidence, questions and some activities done to strengthen the evidence-based policymaking and our challenges and opportunities as well. This is the background about Sudan, the countries, around it. Rural population almost 70%, urban population only 30%. The history of generation of evidence-based, actually the history of the Federal Ministry of Health go back a long time ago. It was established in 1949, even before the independence, which was on 1965. There was a very strong national primary health program started 1973-74, and it was well functioning even before Al-Ma'ata Declaration in 1978. The people at that time in the Ministry of Health made very good decisions, or pushed for very good decisions to do, such as the local manufacturing of the yellow fever and smallpox vaccine, which has been used to be done here in our national laboratory. Most of the research, or the usual things we use for getting evidence are the routine surveys, national surveys, like the Safe Motherhood Survey 1999, and then the Sudan Household Surveys. We have done 2 rounds of that. The Mixed Survey, 1 round, 2014, and the S3M, and many national health account surveys rounds. Also, we have done many disease surveys and surveillances for both infectious and NCDs. And in addition to our routine health information system data, that's the annual statistical report. We use the data from all these surveys and surveillances in doing our guidelines regarding the health programs at the Federal Ministry of Health. Mainly the primary health care programs, including the child health program, the diseases programs. The data are used mainly to prepare those, and the protocols of prevention and curative disease and all that. The good thing is that in the past 20 years, the Ministry of Health used at that time the bad indicators of mother and child health and nutrition to advocate for health issues. To be honest with you, the health issue in the first 10 years of the millennium wasn't high on the political agenda at that time. They were busy about the separation of the southern part of the country. There were many political issues. That's why the health issue wasn't on the political agenda at that time. But I admit that the leaders of the Federal Ministry of Health at that time pushed hard and used very well the indicators came from the surveys I mentioned to advocate for the health issues. That's why on the 2010, actually, there was the establishment of the Higher Council of Coordination of Health, which was headed by the president at the time, and then by the what do they call it, the chair minister or the prime ministers. Many policies has been also developed using the same surveys data in our country. Like the first one, I think, was HIV national policy, which was formulated 2004. That was supported by the UNAIDS. Also, the child health policy, the RH policy, developed in 2005, supported by WHO, EMRO office at the time. And many policies since then has been developed. National nutrition policy, immunization policy, even the national health policy 2007, and many of them actually. I will start talking about the experience, our successful experience actually of using such evidence. In 2011, Sudan, or Federal Ministry of Health, conducted a national survey, which was a mapping survey. It brought very worrying figures that almost 15% of the population had no access to services. The nearest access was more than 5 kilometers, and 25% of the population only get 2 of the 6 essential packages. So the higher Council of Coordination of Health decided to do or establish the expansion project, which involves a training of midwives and other medical assistants and the building and rehabilitation of primary health care. A lot of money has been paid for that. We have got a small but important experience in the Department of Policy. We conducted TOT in 2015 with the support of WHO. The material used to conduct 4 courses at the state level for the planning directors of the state and localities. The idea was to train them how to communicate their problems with the decision makers at the state and locality level. So we guided them to prepare policy brief using their local data, and they conducted also a policy dialogue, and we had a very successful experience that actually the policy brief. The policy brief was discussed in the Blue Nile State Cabinet Minister of Health and has been adopted as a local act, actually. We have got the experience of the Primary Health Public Health Institute in Sudan within the Federal Ministry of Health. They did also family health approach, health finance policy by preparing options and things. They evaluated the National Health Policy 2007 and formulated a new policy 2017 and 30. We have got a few institutes, including all the General Directorate of Health in the Federal Ministry of Health. I think they are responsible and helped in production of all the surveys I talked about. Also, we have done some national events to help strengthening the evidence-based policy, like knowledge transfer activities, advocacy. One of them is Health in All Policy Conference 2016, Research Conference 2018. Our context now, of course, is the context of the magnificent, actually, revolution we have done, but it has got some challenges and opportunities. The main challenges are the unstable political and economic context and the lack of financial support. Of course, we cannot conduct, the health technology assessment or systematic reviews or intervention studies because of the lack of resources, of course, in addition to high turnover of staff and health professionals and the general poor infrastructure. Of course, in addition to the pandemic of the COVID-19 and other some local epidemics. But we have got some opportunities because of the revolution, that our name has been lifted from the list of the countries supporting terrorism. There is a good environment of supporting health system reform in general and more transparency to discuss the health issues in general. Thank you very much for listening.
Many thanks indeed, Dr. Abda. Very inspiring presentation, showing a lot of examples of success in difficult circumstances. But you also did excellent in keeping to time. I'm really grateful for that. So by that, I have the honor to invite our second speaker. So that's Dr. Hoda Basalim from Yemen. She has a PhD and she's a medical director, and she's vice dean and of the Faculty of Postgraduate Studies in the Aden, and she's also director of Aden Cancer Registry. So a lot of academic background, but she's also been involved in the situation of key policy decision in her country. So Dr. Hoda, floor is yours, and I also remind you that you have 10 minutes for your kind intervention.
Thank you, Arash, and all colleagues for this opportunity. This is my presentation title, Yemen Situation While There is Still Challenges of Non-Stability and Urgent Needs of the Health System. I try to be in 10 minutes, first to describe the current humanitarian situation in Yemen, and then to provide an overview of the healthcare system in Yemen and illustrate the impact of this humanitarian situation on the healthcare system in Yemen. And then also, because this is connected to the higher education system crisis, we will describe it. And I propose one things about analyzing the current situation in regard to the framework action and the suggested requirement for its implementation. Yeah. Republic of Yemen, it is the poorest country in the Middle East and yes, and North Africa, population of 30 million. And then according to the World Bank, we are classified as low income country with the Human Development Index rank of 179 out of 189. Yemen is subtropical, dry, and hot desert climate, but currently we are suffering of extreme climate event and natural disaster in the last few years with no, infrastructure to overcome their effect. So around 80% of families are in debt or borrowing money to feed their children, and families are eating less, opting for cheaper food or skipping meals. This is some picture of water scarcity, locust invasion, and the disasters that happen in Yemen, either related to the ongoing conflicts from 2014 or to the those related to the natural disaster. United Nations has declared Yemen as the worst humanitarian crisis in the world. That fighting has devastated the economy, destroyed critical infrastructure, and led to food insecurity verging on famine. Distortion created by the fragmentation of institutional capacity in the central bank of Yemen and other government agencies, and this is big problem in reality. High inflation, exchange rate fluctuation, economic crisis with many employees are not getting salaries for years. In 2020, there are 24.3 million people, that is around 80% of the population, were at risk of hunger and disease, of whom roughly 14.4 million were in acute need for assistance and weak public infrastructure. An estimated 20.5 million people are without safe water and sanitation, and 19.9 million, or around 20 million, without adequate health care. There are mass outbreaks of preventable diseases such as cholera, diphtheria, measles, and dengue fever, and recently COVID-19, of course. More than 40% of Yemeni households are estimated to have lost their primary source of income, and poverty is worsening. It was, almost affecting half of the country population before. Now it affects estimated 3/4, that is between 71 and 78%. And we have the problem of internally displaced person, which reach now around 4 million. This is the healthcare system in Yemen. We have a public and private healthcare system. We can see here Ministry of Public Health, which is the major provider, with having hospital, health center, and health unit. We are also having the Ministry of Interior and Defense for police hospital and military hospital. Also some contribution from Ministry of Water and Environment for environmental health related issue, and Ministry of Education for school health. For the private, we have for-profit and non-for-profit hospital, health dispensaries, health centers, and health unit, and polyclinics. And those who are not for-profit, mostly by international organizations like Red Cross and so on, and some local NGOs. This is the health system in Yemen. We have the 4-level health system. We have at the first level, the primary health care unit and health center. At first level, district and government hospital, governorate hospital at the second level, referral hospital at the third, and specialized hospital at the fourth level. Actually, 65% of the population of Yemen are affected with the bad situation of the health system. As I said, there are around 20 million people need health assistance in Yemen, and this is increased by 3.1 million only in 1 year. And this is regarding as devastation of the healthcare system. Here we can see that is out of 5,000 health facilities, we have 51% only are fully functional, and 35% are partially functional, and 14% are non-functional. And those who are fully functional are mostly working by those humanitarian actors. The healthcare system have many problems and fragmentation forms of health system. So we have many political issues. We have inter-health, according to different providers. We have intersectoral collaboration problem. So many problems are worsening because they are thinking this is a problem only of health, but they are other actors that should work in this, like sanitation and water, but there is no collaboration. There are different agendas. They are interfunding also. It is sometimes stop funding, and leadership also problem in the country. These are some, indicator, but due to shortage of time, I will concern only with those in red color about maternal mortality ratio. After, such increase in over years, now we had, jumping in the maternal mortality ratio into 385 per 100,000 live birth. Also, out-of-pocket expenditure, there was increasing all over the time. It reached now 80%. For the whole country. About the Yemen higher education system crisis, university life is severely disrupted. We have two governments. So the rival governments each have its own minister of higher education, but at the same time, we are as universities or academic, institution, we lack any running cost. And also a number of universities physically shattered. Dozens of public universities had been completely destroyed, and another 25 university buildings were partially destroyed. There is interruption of earning and salaries of many professors and academic staff in the public universities, and this began from 2015. Many are not paid and continue till now. So many professors and academic staff left Yemen. And this is our framework. I took the action. Yemen is found in the or categorized maybe as the category C. So I took this action. So the first four in blue color are related to all countries. The second one in green color is those for the category B, and we are here the last one in category C. So for regarding those related to conflict of interest, it is almost not exist, and this need urgent implementation. Actually, no people may be aware about the conflict of interest and these, terms or not, exist in reality. For enhancing the capacity of the Ministry of Health Planning Department, there are some capacity before, but now deteriorated due to the current situation, knowing that now in Aden is the Ministry of Health related to the internationally recognized government. It is only established 3 years ago. So there are no much capacity. So technical capacity building, redeployment, because we are now seeing people in some position, they are not related to their, background. They are working in some, position, they are, while their qualification are related to other other things. Also, to ensuring the access of the Ministry of Health to source of research evidence like Hinari, we have a problem in the ministry and even in the faculties of medicine about the irregular access to Hinari. It's sometimes stop for us, sometimes the password change and not reached all people and so on. So there are limited use. So this needs supporting regular access. Improving cause of death report and national observatory. Actually, there is no use of death certificate and weak reporting capacity, and technical capacity building is highly required. Support rapid process of adaptation or development of policy synthesis product. It does not exist, and we think that it will be, in place if we set up all the above that we are, mentioned before, all the action mentioned before. Ensuring a minimum capacity about epidemiology and cost analysis. Actually, there are some capacities exist, but mostly we are working with the support of stakeholders. The ministry itself, all its institutions are supported by the humanitarian access. There is no running cost, and all what is happening with activities are by the other actors or the supporter. So we need to promote existing capacities. Finally, we need to, or the action that include resource fund for evidence to policy activities currently not exist. We need policy decision, and this is the political commitment in this regard, and implementation support will be the only one that can support this framework. And this is my presentation, and thank you for listening.
Many, many thanks, Dr. Hodan. Many thanks for beautiful photos that you are putting in the end. I also acknowledge the very interesting table that you put against the framework recommendations and summarizing what are the main challenges and opportunities for Yemen according to that. So it's very well presented. Many thanks. And also you stayed in time as well. So I need to also thank you for that.
Okay, thank you. Yeah.
So the third presenter, or the fourth, I mean, if you count myself as well, would be sort of the Dr. Hania Sajjadi from Iran. She's Associate Professor of Health Services Management from the University Research and Development Center of Tehran University of Medical Sciences. And so Hania, not only as a presenter, but she was also behind setting up this session as a whole in HSR. So I'm also grateful to her because of her efforts on that sense as well. So we are here to listen to your experience from Iran, and you have 10 minutes.
Yes, thank you so much, Dr. Arash. Hi, everyone. My name is Hania Sajjadi, and it's a great honor and my pleasure to be here today. Just I want to be sure that you have my slide.
Yes, we can hear you very well, and your slide is presented. Please go ahead.
Okay, thank you so much. In this talk, on behalf of the social core team and other investigators, I'm going to present the result of our study. We named our study Social Study, which is the short format of evidence-informed health policymaking in Persian language. And it's a national research project to develop a roadmap to promote evidence-informed health policymaking in Iran. I also discussed the challenge the country might have to implement the national institutional capacity for evidence-informed health policymaking. And since I'm mainly interested in governance issue, the challenge related to governance arrangement will be more elaborate. I hope you will find our talk informative. The Islamic Republic of Iran has introduced many initiatives to link research to policymaking. As a result of this initiative, the use of evidence was considered in developing, implementing, and evaluating health policies. However, the use of evidence was not well institutionalized due to some barriers that the country still has. In 2017, the social team decided to adopt a system thinking approach to develop a roadmap to tackle these barriers. And as you see in this slide, the social employed a methodology in which we try to identify the main current and possible barriers of evidence-informed health policymaking, and then we tried to extract and to propose a series of practical and appropriate policy options were chosen based on global experience and the country-specific circumstances. We also decided to ensure that how we can implement the intervention related to evidence-informed health policymaking. So we developed a tool to assess the status of evidence-informed health policymaking in the country and to examine the impact of proposed intervention. We estimated that social lasted for 2 years. I would like to stop here to explain more about the methodology, and if you are interested more in detail, you can find them in our published protocol. Considering the main result of social and what social proposed to promote evidence-informed health policymaking, I would like to invite you to watch a short video clip that briefly introduces the social and its main finding.
Period of 2 years, a national research project strengthening evidence-informed policymaking in Iran, which comprised 19 sub-studies trying to identify the interventions needed in this regard. In terms of methodology, first, the possible and current barriers in the country were identified. Then, a range of interventions were extracted from global experiences. Eventually, using a wide range of opinions obtained from stakeholders and experts in this field, and also by assessing the advantages and disadvantages, solutions appropriate to Iran's health system were recommended. The findings offer four main groups of interventions, namely strengthening learning and motivational system, structures, and supportive processes. 1. Strengthening learning systems ranges from needs assessment to increasing skills at various professional stages. Given the specialization of roles and the significance of collective synergy in decision-making, we recommend that training be team-oriented so that both evidence producers and users have the necessary skills to play their roles in the team. 2. Strengthening motivational systems, shifting from merely encouraging article writing to the practical utilization of health system researches and policies. Motivational strengthening should be at both individual and organizational level. Organizations responsible for evidence production and utilization. 3. Strengthening structures to improve communication patterns between organizations responsible for evidence production and utilization in the health system's policymaking through three main approaches. A. Optimal utilization of existing research centers' capacities and their inclusion in evidence production for policymaking in their respective specialties. B. Coordination and division of tasks among organizations. C. Offering roles to evidence-exchanging organizations to strengthen ties between evidence producers and users. 4. Strengthening supportive process in evidence-producing and policy-making organizations that focus on transparency, accountability, and stakeholder collaboration in the production and utilization of evidence.
Okay, as you all know, and Dr. Aresh mentioned in his speech, the EMR framework was officially launched in 2019 during RC66. This framework includes country actions to help Eastern Mediterranean region countries to improve their capacities for evidence-informed health policymaking. Apart from general actions for all EMR countries, there are some actions for each country based on its category. For example, Iran is a country with large academic capacities and a large population, Group D. So there are some general action for this country and some specific action recommended for improving evidence-informed health policymaking. By the time this framework was launched, SASHA had been finalized and the national roadmap had been prepared. For SASHA team, it was very important to answer this question and to clarify this, that how SASHA can contribute to implement the EMR framework. To answer this question, SASHA team decided to list and to extract all action that in the framework was suggested. You can see all of them in this slide. Let's consider the first one, establish mechanisms to regulate and manage conflicts of interest in policymaking. Conflict of interest was a key barrier and challenge that had been highlighted by SASHA too. And regarding global experience and the specific context, we suggested 9 interventions to address these actions, as you can see them on the right side of the slide. We think that these interventions are a bit more practical and their implementation helps our country to materialize the EMR framework. In other words, we translated EMR framework country action to SASHA intervention. Therefore, we think that preparing such a national roadmap aligned with EMR framework is essential for each EMR country. Another issue that the SASHA team recognized refers to the nature of action and intervention required to implement in this stage. A deep look at these initiatives demonstrates that in contrast with preliminary initiatives to promote evidence-informed health policy making, things such as training, rewarding, establishing new departments, these kind of initiatives are more challenging to implement because most of them focus on the governance of the health system. It means that a further improvement in evidence-informed health policy making needs strengthening the health system governance, and you all know the considerable difficulties of making positive changes in the health system governance. This issue will be more challenging when we remember that making a change in the health system governance depends on the political will to change the governance arrangement of the country. Let's give an example. If we want to manage the conflict of interest in the health system, one intervention can be being transparent and disclosing the information, some information about the name and vote of policymaker or funder. It is hard to think of or establish a transparent mechanism in a health system as a subsystem of a country while being transparent. I mean, clarifying the name and vote of our representative in parliament is still a controversial topic in our country in high level and in macro level. So the question and the concern is this: how we can strengthen the health system governance without any interest or low interest of making change in the country governance arrangement. I would like to finish my talk with this key message. First of all, we know that the EMR framework is a very helpful guide for EMR countries to promote evidence-informed health policy making. However, to materialize EMR framework, each country needs to develop its own roadmap, such as Sasha for Iran. Second, as a part of institutional capacity building, countries need to think how they should strengthen their governance arrangement. In absence of a good governance, implementing of key intervention to promote evidence-informed health policy making are challenging and sometimes impossible. And last but not least, I want to conclude that it is important to have a sound idea, to have a plan, to have a roadmap, but the really important things is its implementation. Thank you so much for your attention, and over to you, Dr. Arash.
Many thanks indeed, Hania, for excellent presentation as previous speakers. And also, I really like the way that you link the sort of some assessments in the country, in Iran, to identify what should be done for improving evidence-informed policymaking with the EMR framework for that. And the final message actually is the key for any implementation, any policy. In fact, so without implementation, policy does not make a change, and that's absolutely true. Okay, I would like to invite the next speaker. So that's Dr. Rasha Fadlallah from Lebanon. She's a researcher at the Department of Health Management and Policy at the Faculty of Health Sciences of American University of Beirut. And she's a key member of the K2P Center of AUB, American University of Beirut, which is one of the well-known units globally in terms of evidence to policy. And she also works with the Spark Center, another relevant center in Lebanon. So she's going to share with us the Lebanon experience. Hani, I think you need to stop your screen sharing so that Rasha can share her screen. Rasha, it's over to you, and you have 10 minutes, please. Rasha? Great, thanks.
Yes, thank you, Dr. Arash.
Go ahead.
So in my speech, I'll be specifically focusing on the experience of the Knowledge to Policy Center in strengthening capacities and collaborations with the Ministry of Public Health in Lebanon to promote evidence-informed health policy making. And I'm going to start my presentation with the rationale behind the establishment of the Knowledge to Policy Center. So prior to the launching of the center within an academic institution, we conducted a readiness assessment exercise to have a better understanding of the perceptions and views of policymakers, stakeholders, and researchers in Lebanon and the Eastern Mediterranean region when it comes to research and promoting evidence-informed policymaking. And more importantly, we wanted to identify what were the key barriers and facilitators to evidence-informed policymaking. So one of the most frequent one of the most frequently reported barriers was the lack of an administrative structure for supporting evidence-informed health policy-making processes. Participants also mentioned the limited value given to research and the poor alignment between research and policy priorities. They also mentioned the lack of trained policymakers and researchers in evidence-informed policymaking. In terms of facilitators, these included communication and networking between policymakers and researchers, having qualified researchers engage in efforts to promote evidence-informed policymaking, having research funding, and promoting easy access to information. Some of the proposed strategies to improve the use of evidence included producing policy-relevant research evidence and improving the packaging and dissemination of research, building the technical capacity of policymakers and researchers, increasing communication and exchange between these two entities, and of course, increasing investment to support evidence to policy activities. So we responded to these gaps and needs by establishing the Knowledge to Policy Center at the American University of Beirut. And K2P is a knowledge translation platform within an academic institution for bridging the gap between research and policy and promoting evidence-informed health policy making. And we opted to have it within an academic institution, given Lebanon is a highly politicized country, so it was important to remain politically neutral and independent so that we can gain the trust of policymakers and be able to influence decision across a range of stakeholders. So this is the impact-oriented approach that we adopt to promote evidence-informed policymaking and practice. And this approach is designed to address factors known to hinder the use of evidence by policymakers. So if we want to achieve impact, we always start with priority setting, where we engage policymakers, stakeholders, and researchers to identify priority issues, because we want the research to be relevant to the needs of policymakers. So once a priority issue is identified, we proceed with looking for systematic reviews, primary studies, and local data addressing the issue. The findings from these different sources are then combined and synthesized in knowledge translation products, which package the evidence in a user-friendly, yeah?
We've received a message that maybe your slide is not visible. Can another colleague tell me, so can you see the slides?
Yes, Dr. Arash.
Okay, so maybe that's one person. So, okay, sorry for the interruption. Rasha, please continue.
Small font though, but we can see it.
Can you see it?
Yeah.
Yeah, okay. Okay, so I was saying, so we then synthesize the findings from these different sources in knowledge translation products, and these are important because they package the evidence in a user-friendly format, and then they tailor the message, the key message, to the different target audience using easy-to-understand language, and more importantly, using actionable format. And this is important because it enables effective communication of evidence, and it also contextualizes that evidence so that policymakers are able to interpret and apply it to their own context. So once the KST product is developed, we then actively disseminate it through a range of knowledge uptake activities. And one of the most prominent one is the policy dialogue that brings together different policymakers, stakeholders, and NGOs to deliberate about the finding and try to reach solution. We also engage in advocacy, we involve media, and we provide support to implementation. We then monitor and evaluate to see what impact has been achieved. And central to this approach is capacity building. So we have invested heavily in building capacity at both the supply side and the demand side. And okay, so it's not switching. Okay, so through the K2P mentorship program, we have been able to develop individual and institutional capacity for evidence-informed decision-making across different LMIC countries. And this K2P mentorship program is characterized by being needs-driven, meaning that it is designed to address the needs and gaps of a given mentee institution. It offers customized training, workshop, and institutional support. It focuses on individual and institutional level capacity. So in addition to building skills, knowledge, and changing attitude, we also want to make sure institutions have the right system, process, and the right culture to facilitate evidence-informed decision-making. And we have a follow-up mechanism to try to sustain that learning. So in the next few slides, I will provide example of impact that we have been able to achieve through our collaborations and partnership with the Ministry of Public Health and through applying the impact-oriented approach. So this is an example on the Syrian refugee crisis. So the large influx of Syrian refugees in Lebanon and the obligation to address their health need has rendered the issue of promoting access to health services for Syrian refugees as a priority. Accordingly, we held the first national priority setting exercise where we brought together the different policymakers, stakeholders, and NGOs, humanitarian agencies, and funders to try to identify what is the priority issue when it comes to promoting access for Syrian refugees. At that time, the problem was not with funding because we had lots of funding coming into the country, but the problem was with the lack of coordination between the different organizations, agencies, and bodies providing or financing health services for Syrian refugees, which was creating duplication and fragmentation. So we searched for evidence addressing this priority issue, and then this evidence was then integrated into a knowledge translation product, which was subsequently disseminated in a national policy dialogue, where we brought together many of the stakeholders who were involved in the priority setting exercise. And the dialogue was an opportunity to discuss the findings and try to reach solutions. So we then prepared dialogue summary, which summarized the key discussion and provided a roadmap for action. And we then followed up closely with the Ministry of Public Health. And through this process, the ministry ended up recruiting a refugee health response coordinator at the Ministry of Health. This led to strengthening the information system of the ministry when it comes to refugees. So prior to that, we did not have data on refugees, and it led to the development of a strategic plan for responding to the health needs of refugees. So these are additional impacts that we were able to achieve across a range of topics, from informing the HIV strategy in Lebanon to informing the accreditation system by incorporating patient safety goals and indicators, to strengthening child protection practices in healthcare institutions, to informing the implementation of the salt iodization law in Lebanon. And with COVID-19 pandemic putting unprecedented pressure on policymakers to make rapid decisions at times of uncertainty, policymakers, they turned to us for trustworthy sources of evidence to inform their decision. And accordingly, we were able to collaborate with the ministry and policymakers to inform different aspects of the pandemic, from hospital preparedness to promoting the role of NGOs and communities and informing the exit strategy. So in addition to impact at the level of policy and practice, I also want to reflect on the impact that has been achieved at the level of changing the culture and receptiveness towards evidence use within the Ministry of Public Health. So over time, there has been a gradual shift from decisions driven by intuitions and personal values to decisions informed by research and data. So there has been better appreciation for the use of evidence, and this has been driven by a growing realization by the policymaker and the Minister of Public Health for the need to collaborate with a broad range of policymakers, researchers, and stakeholders, and more importantly, for the need to complement local data with research, evaluation reports, surveys, and tacit knowledge to inform policy decisions and achieve health policy impact. There has also been increased participation of leaders and staff at the ministry in capacity building workshops, covering systematic reviews, knowledge translation, and evidence-informed policymaking. So we shifted from supply-driven workshop to demand-driven workshop. There has been strengthened interactions between the ministry and academia through shifting from ad hoc interactions to more systematic and collaborative relationships and partnerships with academic institutions. There has been increased adjunct appointments in academic institutions, meaning policymakers are now co-facilitating courses with researchers as part of efforts to bridge theory with experiential knowledge and practice. There has been increased participation of policymakers at research forums and conferences. One prominent example is the HSR 2020 conference. There has also been increased research participation in MOPH Policy Advisory Committee, particularly during the COVID-19 era. Of course, the ministry has been working on promoting institutional access to training modules and programs tailored to the needs of policymakers and staff at the ministry. And finally, there is lots of work being done on strengthening the health information system at the ministry in order to better respond to the data needs and to promote data-informed decisions. So I want to end with some reflections and lessons learned from our experience, from the experience of a research or academic institution collaborating with a policymaking institution to impact policies. So first and foremost, promoting evidence-informed health policymaking requires time and perseverance. It does not happen over time. The work that we have done and the impact we have been able to achieve builds on years of preparatory work, which has included increasing the awareness of policymakers around the importance of research and evidence-informed policymaking, building their capacities, building relationships, and raising demand for evidence. So it needs time and perseverance, but it can happen. Strong leadership support is required to promote a receptive climate for evidence-informed policymaking. It's important to identify champions from policymaking and research institutions who believe in the value of evidence. For example, the leadership and the hard work of the Director General and the Minister was critical to transform the culture at the Ministry into one that appreciates the use of evidence. Also, as can be seen from the experience of K2P, knowledge translation centers and platforms have critical roles in bridging the gap between research and policy and promoting evidence-informed policy making. And particularly in contexts that are highly politicized and where the minister has limited capacity and funding to engage in evidence-informed policy making, it would be strategic to establish and strengthen relationship with academic institutions and knowledge translation platform to help promote evidence-informed policymaking. Of course, understanding the current political system and the national context in which policy decisions are being made is very important. And this contextual awareness is critical so that you can contextualize your efforts and interventions to that context, because as we know, evidence-informed policymaking, it's not a one-size-all-fit. It has to be contextualized. Of course, you have to create demand and value for evidence. We have invested a lot of time in trying to generate demand and value through sharing success stories, showing how evidence played a critical role in the success or a failure of the program, enhancing awareness, building capacity of policymakers, being responsive to their priorities and needs. And it's very important to build trust and buy-in of your policymakers. And we have been able to achieve that through engaging them early on and sustaining their engagement throughout the different process, from priority setting to knowledge translation, knowledge impact, knowledge uptake, monitoring and evaluation. So this engagement is very important. It's also important to manage demand and expectation. The worst thing is to overpromise and underdeliver. In this way, you would lose the trust of your policymaker. You have to remain objective, truthful, neutral, and maintain credibility. And because we were able to achieve that, when the COVID-19 pandemic happened, policymakers viewed us as credible sources of evidence, and they turned to us. And of course, you have to build capacity to meet the demand for evidence, because evidence-informed policymaking requires large supply. And without capacity, you cannot deliver and promote evidence-informed policymaking. So I'm going to stop at this. I'm going to stop here. And if anyone has questions, I would be happy to discuss. Thank you.
Many thanks, Rasha, for excellent presentation and sharing the experience of K2P over the years. Especially, I mean, the recent experience of K2P in the last year with using all that experience to respond to COVID-related challenges in terms of generation of knowledge products and engaging in policymaking is also impressive. So many thanks for that. So I go now to our last speaker. So I turn on to another colleague from the WHO Regional Office in Emro. That's Dr. Mehnaz Khairani. She has a PhD in pharmacoeconomics and pharmaceutical management, and she's going to talk to us about what has followed the resolution of 2019 in terms of further planning for action and implementation of the framework in the region, and what are the main areas of action on that. So Mehnaz, you have 10 minutes. So, and I think we are about 5 minutes behind the schedule as a whole, but I mean, 10 minutes should be definitely fine. Many thanks, Mehnaz. Please go ahead.
Thank you, Dr. Arash, and good day, everybody. I will present the regional action plan for the implementation of the framework for action to improve national institutional capacity for the use of evidence in health policymaking in Eastern Mediterranean countries. I will cover the regional action plan, the regional network of institutions for evidence and data to policy, which is NET2P, and the WHO regional office plans to enhance the use of evidence for policymaking in the region. As mentioned in previous presentations, particularly Dr. Rashidian's speech, the region achieved the important resolution in 2019 on developing national institutional capacity for evidence-informed policymaking for health in the region. In that resolution, and there are several key requests from member states and regional office, which one of them is development of regional action plan for the implementation of the endorsed framework. As presented before, this regional action plan, the framework was endorsed, which is the sort of roadmap for institutionalizing the evidence-informed policy making in the region. And this is a comprehensive framework by considering countries' differences through their categorization based on the population size and academy level. To develop the regional action plan, a series of actions have been taken by WHO Regional Office. In the first step, the literature review was conducted to find the policies and interventions which have been adopted by other countries for enhancing the use of evidence for policy making. Then, after this conduction of literature review, the first draft of regional action plan was developed and shared with key regional and global experts, also circulated within WHO regional office and other regional offices. The draft shared with supporting institutions, which are regional and global relevant institutions, and based on the comments we received, the draft was revised, and the revised action plan presented in the inter-country consultative meeting which held in November 2020 to collect the feedback from the countries. And you can see the link for the summary report of this in the end of the slide. Finally, based on these comments and feedback, the regional action plan revised and finalized. Our vision and mission, and the vision which we follow is the vision of Science and Information and Dissemination Division in the WHO MRO, which envisions a region where all health-related policies, decisions on healthcare development and implementation and innovations are informed by best available evidence from verifiable knowledge, research, and reliable information. And our mission is this action plan intends to support the countries of the Eastern Mediterranean region in institutionalizing use of evidence in policy making for health through establishing required processes, structures, and capacities at national level, enhancing WHO support for the countries in these areas, and engaging regional experts and stakeholders through effective networks and partnerships at the national, regional, and global levels to enhance effective innovations toward universal health coverage and health-related sustainable development goals. Okay, this slide depicts a general structure of the regional action plan. As you can see, there are two main strategic directions, one for member states and another for WHO, and comprising 3 strategies in each of these strategic directions. Within each of the strategies, there are actions, and each action includes a number of deliverables and activities. In order to effectively cover different needs and priorities of the countries in the region, the deliverables for WHO side are categorized, as you can see in this slide, are categorized in accordance with the endorsed framework. And for countries side, the deliverables and activities are categorized into 3 essential, desirable, and optimal levels. What does it mean? This classification is developed for gradual capacity building of the countries in the region, which means the deliverables defined as essential category are must-to-do activities. That is a necessity for ensuring the country program is in line with the expected directions. Optimal level is meant to demonstrate the status in which one expects a strong institutionalizing of evidence-informed policy making for health in place. So this level of capacity may or may not be required for a given country, and hence the plan is subject to interpretation and adaptation to national settings and based on the country's differences and capacities. Okay, in this slide, you can see the strategies and actions which are defined for countries, and they are going to support by WHO. The first strategy intends to improve the evidence-informed policymaking climate among policymakers, researchers, and key stakeholders. The second one is the strategy for capacity building of the Ministry of Health in the countries. And in this strategy too, we have several activities which continues by each other, which starts by capacity building of Ministry of Health, then continues with creating and establishing the teams and network in the national level, then reforming decision-making process and structures, and finally, there are activities for establishing an integrated national system for evidence-informed policy making. And the third strategy, as you can see in the slide, there are actions and deliverables to be conducted by countries to ensure national health sector about the sustainability of the developed system. And these are the strategies which define for WHO. And as you can see in this strategy, the first strategy are the activities and deliverables which enhance the capacity of the WHO regional office and the region itself to be able to support the countries in the region. And in the second strategy, there are the activities which are going to be taken by WHO to support countries and to enhance the technical capacity of the countries in the region. In the third strategy, we define the activities to improve and to enhance the regional office structure to be able to support the country's needs. For example, we want to establish a regional network of institutions for evidence and data to policy, which is Net2B, and I'm going to present it in next slides. And we are going to have the secretariat for this Net2B within the WHO regional office. Okay. Another key request in resolution in the regional committee in 2019 was the establishment of regional network of institutions to actively support evidence-informed policymaking at national level. This network will have an important role to strengthen the regional and national capacity to improve availability, quality, and use of evidence for decision-making in the region. Who are the main actors of this network in the region? Okay, the main actors are member institutions, which are the national institutions nominated by the countries in the region. Also, the Net2B Secretariat, which is located in the regional office, the steering group, which are the global and regional experts. And we have supporting institutions and partners as a member of Net2B, which including the relevant global and regional institutions, relevant institutions. The member institutions and the national institutions are academic institutions, policy development institutions, governmental or non-governmental, public and private institutions, but the criteria of them are they should play key roles in collaboration with Ministry of Health. They should have the capacity or experience of different steps and processes of evidence-informed policy making, and they should have the minimum human resource capacity and have required hardware and infrastructure, and also they may have history of collaboration and partnership with other related national, regional, and global entities. What are the roles of a national regional network of institutions in the region? It has two main roles, one for national level, and Net2B is going to have close collaboration with the Ministry of Health, will strengthen methodological capacity to enhance the use of evidence for policy making in the at the national level. It will provide the quality evidence that address policymakers' needs. It will engage in monitoring and evaluation framework of the countries, and also it will assess the impact of using evidence in policy development activities on policies and on health outcomes. And what are the main roles of Net2B for WHO regional office? It will provide technical and executive support of the framework for action to improve national institutional capacity for the use of evidence in policy making, and also it will support mutual learning of experience and seek regional and international collaboration and promote the partnership at national, regional, and global levels. Okay, what are the supporting institutions? There are some regional and global relevant institutions that are recognized as supporting institutions for Net2B, and these supporting institutions are going to technically support Net2B members to enhance use of evidence in policy development, and also it's going to support WHO regional office in line with the Net2B objectives and the regional action plan. It is going to recognize national and regional experts and enhance national and regional champions. Also, supporting institutions will support WHO regional office to expand its regional institution. And in my last slide, you can see what are our plans for enhancing evidence-informed policy making in the region for this year and the next year. We, based on the feedback we received from the countries, we are going to develop the relevant tools and guidelines based on the priorities of the health of the countries, of the needs of the countries. Also, we are going to have some training programs, meetings, webinars on this issue. Also, to meet the high health priority problems in the region, we want to develop the regional policy briefs and other knowledge products. Thank you, Dr. Arash. Over to you.
Many thanks indeed, Mehnaz, that in a very short period of time you summarized a very important set of actions that follow the resolutions. So we are, according to our time, we are actually exactly on the time, which is the end of the session officially. However, the organizers have kindly informed me that we can go over for a few minutes if there are questions. I didn't see any questions in the chat room. Let me check again. Yep, I don't see any questions there in the chat room. So my only thing is that if the panel, I open to the panelists, if they wish to give one statement in reflection of what other panelists have said, and then we close on that. So the one statement should not exceed maybe 1 minute perhaps each, if that's okay with Kali. So I go in the same order. I would like to invite Abda first. Abda, please, do you have any reflection? 1 minute, please.
Okay, thank you very much indeed, Dr. Arash. Actually, all the presentations were really very good and informative, especially the experience of Iran and Lebanon, actually. They have got, they showed us really a very good experience, and I like the idea of the Lebanon of their work in the area of evidence-informed policy making, preparing the policy briefs and doing the systematic reviews and priority setting sessions and dialogues, and it was really and creating the demand actually of their decision makers at their country. I think we all can make use of this good experience to try to adopt in our countries. Thank you.
Many thanks indeed, Abda. That's well noted. Hoda, over to you. Your 1 minute reflection, please.
Thank you, dear Arash. This is really great opportunity to take part in such, panel. Yes, all the presentation for me is very useful, and of course the framework, working on the framework and learning about it is very useful. I think we will get, practical steps in our situation to get benefit from all this experience from the region. Although it might need time and harder efforts than any other country in the region. Thank you once again. Over.
Many thanks indeed, Hoda. So now I turn over to Haniye for your 1 minute reflection, please.
Thank you, Dr. Arash. All presentations were very informative for me, and I want to say that our journey to improvement the evidence-informed health policy making in the region is a long-term journey, and we should pass every step by step and gradually pass this way. What is important is that now we have a clear picture of the desired future for all member states, and at this time we need to it's our responsibility to implement these actions and make the real change in our region. Thank you, Dr. Arash.
Many thanks indeed, Hania. So now it's Rasha's turn. Rasha, your 1 minute reflection, please.
Yeah, thank you, Dr. Arash. So it was interesting as well to see the variations in the approaches that have been adopted by the different countries as part of their efforts to promote evidence-informed policymaking. And this further confirms that really evidence-informed policymaking is context-specific. We have to understand the context and tailor the suite of activities, products, and approaches to that given context. And really, we are now at a point where there is a huge opportunity to invest in evidence-informed policymaking. As we know, in the post-COVID-19 era, much of the global and national efforts will focus on strengthening and reimagining existing health systems and public health. And I believe that evidence and evidence-informed policymaking will be at the heart of this. Organizations, initiatives, and networks supporting evidence-informed policymaking are an integral component of this reimagining. So one of the best investments that we can start doing now is to start investing in strengthening these entities to support a more proactive and swift response to priorities, needs, and emerging and future pandemics. So this is an opportunity, and I think this is a timely session, and hopefully we can build on it and take it forward.
Okay, many thanks, Rasha. So now I hand over to Mehnaz, your 1 minute reflection, please.
Thank you, Dr. Arash, and thank you for all presenters. It was a great panel. I want to say that I am so pleased that region have a robust resolutions on evidence informed policy making, and is highly supported by the regional office and also by the countries in the region. And I hope with the collaboration of the countries, we will achieve the optimal and the main goals in this regard. Thank you.
Many thanks indeed, Mehnaz. And I make also my 1 minute reflection. In a way, perhaps I follow what Mehnaz said. I mean, the point is, as I mentioned, there have been resolutions by the WHO before, and resolutions of WHO, they mean agreement of ministers of health. So they are of high political and policy value on evidence-informed policymaking. So for a long period of time, but this is the first time that the resolution involves commitment for institutional capacity building. And that's extremely important. So it's not just about sort of we want to use it and sort of increasing the number of cases, because the cases are many, but then we know more than the ones that are successful. There are cases that the evidence is not being used for decision-making. So we are all aware of that. From WHO side also, many of these activities are not new. They are happening over the years. The challenge we have, they are focused on programs and are focused on issues rather than focusing on institutions to ensure that there is a continuity. So I refer to what we heard from Abda. So I mean, in her slide, there was a nice thing that she was referring that the establishment of Minister of Health preceded the independence of the country. So that's, I mean, a historical fact, but I mean, that's also, there is a message there that the institutions matter. And if in the institution, there is a sort of a structure for a certain program, when politicians change and the situation change, the structures will ensure that there is some continuity. So this focus on institutional capacity is extremely important. And the good thing is, not only the ministers of health have committed to that, so we know the capacities differ, we know that the needs are different, and we know the context is also very different, and that has been reflected in the resolution. But also the WHO is very committed to this program as sort of the leading regional office in this area of work. So by that, I would like to thank our excellent panelists. I mean, group of colleagues with variety of experience, excellent presentations, to the point and in line with this decision. Obviously, we all work together with the same aim of improving policymaking processes to enhance lives of people and ensure people are healthier and live sort of a happier and longer life in the context that they deserve. So I also would like to thank HSR 2020. Obviously, we are in 21, but this is COVID era, and that the event that was supposed to be in October was postponed and became virtual. But I'm really grateful for the opportunity that the Health Research Symposium has provided for this important discussion. Thank you all, and have an excellent rest of the day. Thanks. Bye.
Thank you. Bye-bye.
Thank you, Doctor, and bye.